Hello, everyone. Welcome to the Imaging Wire show. My name is Jake Fishman. I'm the editor of the Imaging Wire and the host of our show. And I'm very happy to welcome Dr. Orit Wimpfheimer to our show. She is the Chief Medical Officer at Zebra Medical Vision and also leads product strategy there, which seems like a really big job. She also has quite a career on the clinical side of radiology before she joined Zebra, and there's a whole lot we have to learn from her, and I can't wait to introduce her and then do that learning. So welcome to the show, Dr. Wimpfheimer.
Thank you so much for having me.
It's a pleasure. It's all mine. So we'll just jump right into it. First of all, once again, thank you for being here. And you have a really amazing background in kind of career, both on the clinical side and then now on the commercial side of medical imaging. And one thing that's really interesting to me is that you have essentially been practicing as a U.S. physician from Israel, which is at least new to me. And I'm curious how your path kind of brought you to there and some of the things that you learned about global healthcare systems along the way.
Absolutely. So I trained in New York at Columbia Presbyterian. I did my radiology residency and fellowship, but I really wanted to move back to Israel. I was actually originally born in Israel, but I left when I was a baby. So I grew up in New York. But I wanted to go back and raise my family here in Israel. And I tried to figure out how to do that. This was a little in the earlier side of globalization, and ADSL wasn't even created yet. It was in the process. So it wasn't completely clear that we could actually move so many images, which now seems so obvious to everyone. But 20 years ago, it was not obvious to anyone if we can make it work. But I was really, determined to move to Israel. And I figured, the worst comes to worst, I'll get a job in Israel, but I'd rather stay and work in the US healthcare system because that's how I grew up. That's where I trained. That's where I saw a lot of value in my career path. So I met a partner who wanted something similar, and we figured I'd be the guinea pig. He'd stay in New York and run the New York end of the operation, and I'd be in Israel. And we would try to create our own little teleradiology practice by servicing hospitals on the East Coast, taking advantage of the time difference between the US and Israel, which is 6 or 7 hours, usually 7 hours. And then I would read the images done at night in the ER in the hospital, and the typical teleradiology Nighthawk system, and he would manage it from the side. And so I was a guinea pig. I came to Israel. And we had our first hospital, the hospital he was working at, and then we slowly added another hospital. And by the end of the year, we had a nice group of hospitals all in the Pennsylvania area that I was reading their radiology, whatever came in at night from my home here in Israel, from my home office. And he saw that it was so successful, he moved the following year, and we grew our teleradiology practice, which is still working, Remote Radiology International. We service hospitals in Pennsylvania, New Jersey, Massachusetts, and we continue to work. We have many radiologists who work for us, some present in Israel, and others present in the United States, some even on the East Coast, some in California. The world is very global at this point. And we service our hospitals 365 days a year. What's nice about working in Israel is that I work during the day. My shifts are 6 a.m. to 3 p.m., and that covers the nighttime on the East Coast. So even though teleradiology is a Nighthawk is typically night hawk, our Nighthawk is actually day hawk from our perspective. It makes it very, very effective. It also makes for a very nice experience for the physicians that we work with all the time. We're awake, we're working, there's no tired issue or frustration issue. I've been working with the same physicians for the last 20 years, ER doctors, trauma surgeons, neurosurgeons that we know each other really, really well, but we've never met, given the distance.
Right. That's amazing. And I love Dayhawk. That seems like a much better shift than Nighthawk.
Yeah.
Are there certain things that you kind of really stuck out at you as the differences between, say, the healthcare system that you're a customer of at home and the one that you serve in the US?
Actually, it's a very stark difference in the typical fee-for-service system in the United States. You could tell that money drives the issue, and sometimes I find tests, including in the ER, being ordered unnecessarily. And there's a lot of fear of legality. So tests are ordered to kind of make sure I don't miss something, even though the likelihood is nearly zero because of a concern for medical legal. So the fee-for-service concept of like money driven and the legal issue of being scared about what might happen should you get sued are two very big negative factors in the US healthcare market, although that's changing. That's changing nicely now. I'm watching it as value care health is changing in that direction, and large IDNs who are really taking care of patients, but also the medical risk holders. So that whole paradigm is changing, which I'm really happy to see. In Israel, we have HMO systems. So you have 1 of 4 HMOs. You're completely taken care of from A to Z, and it works really fantastically, as we see now with our whole vaccine drive and our level of COVID, which our country is completely open and everything is totally fine. My daughter had a wedding of 400 people just last week, and that's really, really nice. And it's 4 different health HMOs, which you can move from one to the other. So that creates the competition necessary to make sure the quality of care remains high. So it's nice in that way as well.
Got it. Well, congratulations on your daughter's wedding.
Thank you.
I understand, in addition to building out your radiology team, you've built up quite a family during your career. So,
Yeah. I don't want to kind of be shocking to our viewers, but I have 9 children, of which 6 are now officially married, and 3 younger ones at home. And between those, we have so far 4 grandchildren. So yeah, the house is busy. But listen, all these years, I worked from my home office. So it was a really nice family life balance. I was able to continue my career and work and earn income. On the other hand, my kids knew that I was always available for them, because they would walk into the office and walk out. And if you need to drive over to school quick because your child missed their lunch at home or something, then the school is 2 blocks away. That's easy to do during a shift. So it was a nice work-life balance from that perspective as well.
right, that makes sense. It works that way for medical imaging newsletter publishers too.
That's good.
Excellent. So more recently, you've made a big transition in terms of to the commercial side. How did you make that decision?
So about 20 years ago, we were really at the forefront of the teleradiology revolution in radiology, which was the last major revolution in radiology and changed how people work. And I really enjoyed being at the forefront and building out my company. And over the years, I really focused on working, but also on my family and building out my family. And as the kids are growing up and getting married, I really wanted to find a new direction in life. And the real revolution happening in radiology as we speak is the artificial intelligence revolution. So about 2.5 years ago or 3 years ago, I started really researching the market and understanding kind of the good things, the bad things, the unrealistic expectations and the reality, and really researching it in depth. And I chose to join Zebra Medical Vision with the hope of kind of bringing in the radiology perspective, which I felt was lacking in general in the market, to try to direct the company into a direction that I think would be successful.
Awesome. And you are, I guess, as of recently, both the chief medical officer and then also the head of product strategy, which seems logical, but also is something that I haven't seen a lot of.
So I started at Zebra as a clinical director and kind of really learned the AI market and the ins and outs of actually creating an algorithm and creating the platform and the end-to-end solution. I had a lot to learn. This is a new field for me. But I quickly rose to chief medical officer when they realized the value of bringing radiologist perspective into the company, rather just as a consultant, but more as someone who would drive the thought of how we would move forward. And over time, we realized that there was still a disconnect between the product strategy versus the chief medical officer position, because I had more of a consulting role or a suggestion role, but the product people weren't necessarily listening to what I was saying. People found value in what I was saying. And we decided that ultimately clinicians have to drive artificial intelligence for it to be done right. And it's really hard to come from industry and from products and from business and kind of impose that on radiologists, because there's that disconnect between how product would see it if they don't come from radiology world versus how a clinician would see it. So we combine the roles. It's actually a huge role right now, but luckily, as I said, most kids have left the house, so that's okay. And it's combining the two together and really, really driving the strategy through the radiologist lens that is gonna hopefully, that actually changed our product roadmap and changed our direction into a direction we're much happier with and much more comfortable with. And then we were originally leaders of the triage use case for radiology, and now we're leading, I think, the market in a different direction, which we're really excited about.
Tell me about that direction.
Well, I made that one easy for you. The triage use case is the natural initial use case that you can bring into artificial intelligence, because it's very obvious for a busy teleradiology practice. to create, the notifications of the intracranial hemorrhages or the pulmonary embolism to kind of get those cases read faster. It seems a natural fit for artificial intelligence. There's also a small segment that would increase the sensitivity of finding those things. There are always these, minor misses here and there that radiologists or radiologist residents or people less experienced might miss on the course of a given day, especially if they're reading at night and they're tired or they might be missing it. So that was a natural first use case. And we went into that full steam ahead, as did many of our competitors. And what we found when we got into the market, which is something that I said right when I walked in the door at Zebra, is very nice and dandy, but I don't need that. We actually read pretty effectively. We've been doing teleradiology now for 20 years. We have our own mechanisms in place to how to get urgent cases to the top of the list. We have, CT technologists who are well aware that if they see a bleed on a CT scan, which is, a big bleed, which are the ones that are most urgent, really, they flag it for us and we know to read those cases first. The ER doctors have a system where they can flag cases for us for patients they're particularly concerned about. So radiology has inherently created those initial systems for themselves before artificial intelligence came on the scene. So it might add value, but does it really add enough financial ROI to warrant that kind of investment? And so many companies are still going in that direction, but when I walked into Zebra and I said, I'm glad you're making those products, I don't want them for my teleradiology practice. So I'll help you try to sell them, but I'm not enthusiastic about that direction. We really kind of took a big step back and said, okay, well, if artificial intelligence isn't creating that much value in triage, where can it add a lot of value? And then let's hone in on that and see if we can really bring that to the forefront of radiology and really kind of take advantage of what artificial intelligence has to offer, which right now is not fully utilized, and really steer the company in that direction. So that's what I'm helping to do here at Zebra. And then you're going to ask me what direction is that. So I'm going to continue on and say that we're very excited about the population health initiative that we are creating here at Zebra, because what I found in my experience, and there are many, many published papers to show also in the clinical world, there are many, many things on the CT scans that radiologists don't spend the time mentioning it. There is a lot of data, a lot of hidden data or very overt data on the CT scans, and the radiologist has a limited amount of time to spend on that CT scan and a limited amount of patients to create very, very long reports. So certainly the radiologists are excellent at their field, including my company and others as well. And we know how to read the cases, and we get all the appendicitis and the diverticulitis and whatever small bowel obstructions, and we find them and we get the patients treated, and I have nothing but regard for the radiology world. But sometimes the chronic, kind of less important things on the CT scans get left out from the radiology report because radiologists don't find necessarily that much value in it. We're not kind of trained to kind of discuss every minutia on the CT scan, because then the reports get very, very long and difficult to read. And so isn't consistency among radiologists to really identify those chronic conditions and get them alerted to. And even those radiologists that do spend the time to discuss every little thing that is not acute, often that information gets kind of stuck in the body of a radiologist's report and nothing happens with the patient. So there's clearly a missing piece here of dealing with chronic medical conditions, alerting and identifying them on the CT scan, getting them onto the report, but also getting them then to the hands of the primary care physician or the specialist, so that this patient can be identified at the earlier phase of their condition and actually get treated and not get lost in the system and not get kind of stuck in the world of data without actually actionable items to be able to treat the patient. And I think artificial intelligence as a partner to try to identify population health findings, but more importantly, get the information to the hands of the right physician is a huge, huge benefit for artificial intelligence. And that's where we've pivoted our entire company to do exactly that.
Awesome. AI is a partner, seems like something that people can get behind. Is Zebra working with healthcare systems today to kind of figure out this population health pathway?
We're trying to transition from an AI algorithm company, as many startups started to be, really to an end-to-end solution for dealing with chronic medical conditions. As I said, finding an algorithm, many people can make an algorithm, many universities are making algorithms. It's not so hard to make as long as you have data. But getting that information to the right physician, that's actually been a challenge, especially in the American healthcare system, where it's not user directly to PCP. There's a lot of fee for service. There's not always the right incentives in play. And the medical risk holders are often disconnected from the patients they serve. So there's a lot of disconnect in the American healthcare system. And that's the challenge we're trying to deal with right now. How to get the information that's on the images to the radiologist, to the primary care physician, and to the patient, so that the patient could get the appropriate care that they need. And we're working with Intermountain Healthcare System, and now we're other contracts throughout the United States that I'm not fully privy to disclose right now, that are really working with us to create that end-to-end solution, so patients get on the appropriate care pathways and then prove the benefit of really identifying these findings earlier, so that there's long-term benefit for the patient, which is ultimately at the center of our discussion, but also financial benefit for the medical risk holders, because you don't get to that more end stage of the disease, which is much more expensive proposition.
For sure. So obviously there's a certain type of healthcare system where population health AI would make the most sense, at least starting off. Who is that obvious type of healthcare
So
system?
we're right now targeting a large IDNs, and in IDN, the patient is the fully taken care of, and the medical risk holders and the managers of care and the treatment are all within one system. So there is an inherent benefit for large IDNs to identify these chronic medical conditions, treat them, because ultimately it will show financial ROI based on these findings. So anyone that's the same institution that takes care of patients but also holds the medical risk are particularly suited for this kind of population health initiative. Ultimately, I think doctors really want to do well for their patients. So even in a fee-for-service environment, doctors who are inherently interested in benefiting patients should also get on the bandwagon. However, that'll probably be a later step. Once we prove the outcomes data and the financial data over time, then that'll be easier to sell. But right now, the large IDNs are our target market because they have benefits on both sides of the equation.
How, for the population health teams or departments within these large IDNs, how top of mind is kind of imaging AI and what they can pull from it for them?
Well, we're still very much trying to educate the market. This is a new concept. This isn't something that was there before. We're kind of, population health is important, and that's being spoken about a lot. Value-based care is important, and that's being spoken about a lot. And any IDN that has those initiatives in place, the population health executive officer and value-based care as a forefront for their future mission, want to speak to us and want to let us in the door, at least to hear what we have to say. When we show them what we can do, they're very excited because it really, really lends well to their initiatives. And they're not, population health and value-based care is spoken about a lot, but it's not so easy to make that happen. And there are a lot of initiatives and new ideas as to how to make that successful. But AI is one of those ideas that can really kind of crack that nut of how to get the right patient care to the right patient in a cost-effective manner that'll also be financially rewarding for the institution as well. I think we are that company, and we're very excited with all the conversations we're having throughout the United States, and we're certainly happy to have more. And I think that population health and value-based care, it can really revolutionize the American healthcare system, which really requires revolution. And we saw particularly now with the COVID epidemic, the really huge differences between patient management, patient care, and ultimately mortality among patients, depending on what kind of medical system they were involved with and their backgrounds and ethnicities and race. And there's a lot of inequality in medical healthcare. And I feel like if we identify these kind of conditions, it's ethnically, unbiased. The images don't say whether, you're Caucasian or something else. And so identifying, and a lot of the minorities actually have a higher rate, for example, of cardiovascular disease. And these patients are going undiagnosed and untreated because they're not in a good healthcare system that really pulls out that information. They don't really see their doctors regularly every year. They don't get the preventative healthcare the people might be getting. And so if we can highlight that information on a random CT scan that they got because they came to the ER for appendicitis, and get that information to someone who can then say, listen, this person has cardiovascular disease. It's very nice to have appendicitis. That's not going to kill them. but cardiovascular disease might. And so we flag that patient as someone that should be looked at and treated for cardiovascular disease. That could really change the course of that patient's future. And that's what we're trying to accomplish. And we're hoping with enough interest in the market and enough partners out there, we can really make at least a small dent in the racial disparity and the inequality in the American healthcare system, and really in the world at large. But right now we're focusing on the US market.
Right, absolutely. Are there certain, I guess, chronic illnesses that you're focusing on first?
So we have two very mature products that are already ready for market. One is identifying vertebral body compression fractures on a chest or abdominal pelvic CT scan. These are fractures that are considered minor fractures that are caused by osteoporosis. Osteoporosis is the decrease of bone mineral density, and it happens with age. It's extremely, extremely prevalent, and most people do not get diagnosed with their osteoporosis until they have a very serious fracture, often a hip fracture. And once you have a hip fracture, about a quarter of those patients die within the first year from complications. And even those that survive, many of them often require assisted living. They get pneumonias. They kind of deteriorate after their hip fracture. If we can identify patients at an earlier phase and those patients are at risk for the hip fracture and treat them, we can decrease the percentage of hip fractures that are prevalent and really change a person's life. Right now, there are about a million new hip fractures in the United States per year. And if we can even just make a small dent and decrease that to, by half, by half, that is affecting a lot of people and their future. If we can find these vertebral body compression fractures that often go undiagnosed on a CT scan that's done for pneumonia or small bowel obstruction, not every radiologist highlights it, but even those that do, that information gets lost in the body of the report, and the patient doesn't get treated for osteoporosis. And we're trying to create this end-to-end product that really highlights these patients. To say this patient, it's very nice to have small bowel obstruction. They also have osteoporosis. They are very high risk for a hip fracture because they already demonstrated they have a minor osteoporotic fracture, which is these vertebral body compression fractures that are asymptomatic. And therefore, these patients should be targeted for pharmacological agents and behavioral changes, fall prevention programs to be able to decrease their hip fractures. So that's a very mature product that's already showing benefit in multiple places. The next product is actually getting FDA approval, God willing, next month. We're at the final stages with the FDA. And that product is identifying the coronary artery calcium on a non-contrast chest CT and quantifying it. We identify all the plaques and we measure them, and we give what's called an Agatston equivalence score. Now, Agatston is a measurement on a cardiac gated CT scan of the amount of calcium in the heart. That's a test that is underutilized because it's not paid for by insurance companies, and its value is of limited value in a standalone exam. So in order to have another exam, you have to pay for another exam, typically out of pocket, because insurance companies aren't paying for it. And then you have added radiation, an added appointment at the imaging center in order to get that study. So it's never really been inculcated well into the cardiology workflow or into the primary care physician workflow as an additional test. But that information is really available on all chest CT scans that are non-contrast. So if you have your CT scan for COVID or for ruling out a lung cancer and a lung cancer screening program, there's free information available on that just goes underutilized. The calcium plaques in the heart are on that exam as well. It's not a cardiac gated study, so there is some motion artifact, and radiologists might mention the presence of cardiac calcium, might not, certainly can't quantify it because we don't spend the time measuring out each plaque. Radiologists don't have time for that. There's no automatic way to do that, but we taught our AI to do that. We taught our AI to exclude motion artifact. We taught our AI to exclude stents, so we don't identify patients and overcall them because of the metallic hardware in the heart. And so our AI quantifies the amount of coronary calcium in the heart and separates patients out into 3 risk categories. Those that have less than 99 or less scoring on the calcium have 0 to mild disease and nothing needs to happen to that patient. But those patients that have 100 to 399 Agatston equivalent scores should be treated, should be identified. They should have a cardiovascular risk analysis on that patient. And in the cardiology workflow from the American College of Cardiology, those patients are typically recommended for a statin therapy, which is a very easy therapy to provide. It's a cheap medication. It improves your lipid profile and really has shown significant decrease in the frequency of cardiovascular events and heart attacks future down the line. So, but these patients are walking around our communities without knowing they have cardiovascular disease. About half the patients who find out they have cardiovascular disease, they find it out with their first heart attack. But why do we need to wait for that first heart attack if the information is right there on the imaging? And then patients who have Eigenson equivalent score of 400 and above, those patients even need more aggressive evaluation by the cardiologist. If the patient is shown to have symptoms and there are other factors the cardiologist take into account, those patients are often led to more significant invasive analysis with angioplasty and stenting and whatever intervention the cardiologist deem necessary. We're just there to highlight patients for further evaluation. We're not here to tell them what to do. We're not here to force the cardiologist's hand in any way. We're just here to say, here's a patient, they may not be known to the system, that has cardiovascular disease. Please take this patient and analyze based on risk factors, based on history, based on symptomatology, and decide how to best handle this patient. But at least here he is, or she is, and then please continue on with the treatment pathway to get the patient the care that they need. That has statin therapy by itself has shown to decrease cardiovascular disease. Lifestyle changes has been shown to decrease cardiovascular disease, and certainly if the patient needs intervention, that also could be a life-changing intervention to be able to prevent the serious heart attacks and ultimately often lead to death or cardiac failure as well. Those are our two most mature products. We have a very, very rich roadmap that really focuses on population health and different on CT scan for now, but we even have thoughts of going on to MRI in the future for different diseases to really kind of hone in on the chronic conditions and try to get these patients the right care they need.
God, you have been busy. So in the US, and I don't know if you have these numbers, but how many patients would just say all healthcare systems turned on this kind of incidental screening for these two, for the osteoporosis and for heart disease? How many patients would get screened each year who wouldn't otherwise?
Yeah, so the number of CT scans performed per year has been exponentially increasing for the last 20, 30 years. I experienced that myself in my own teleradiology practice. We've had to hire more radiologists with the same number of hospitals just because the numbers of imaging has increased dramatically. And certainly now in the era of COVID, chest CT scans are performed very, very frequently because of concerns for complications for COVID. And so there are plenty of patients out there. Now, certainly we don't screen the entire population. Anyone who hasn't had a CT scan for some other reason wouldn't get screened. And we're not proposing creating those CT scans, not the cost, not the radiation, not the effort, not the patient anxiety. We're not doing any of that. But what we are doing is taking advantage of the data that's already created for some other reason and making sure that all the data gets utilized properly. I mean, in the modern world, any data that doesn't get utilized is a loss, right? I mean, ask Facebook, ask Amazon, ask any of the big companies. Data is really, really where all the, benefits are, right? If you can understand how to use data, then you can make a big impact. So I don't really want to make impact in the world of advertising and marketing, which is what some of the other big companies do with all our Facebook and Amazon use. But I do want to take advantage of the data to improve healthcare. And I think that if we don't, then that will be a big loss to the world at large. And if we do it correctly, that can make a very, very huge impact. These are chronic conditions that are pervasive. Cardiovascular disease is the #1 killer in the world, worldwide. I mean, #1, right? Everyone's talking about COVID, but that's not the #1 killer, not even this year. So osteoporosis is one of the most pervasive chronic illnesses in the elderly population. And with the baby boom, there are huge numbers of patients in that age category right now that are undiagnosed. And it's great to talk in big numbers, but it's also great to talk about individual patients. I mean, we've had particular stories of people calling us up and saying, wow, I'm so glad that I happen to have been in a hospital that used your algorithm, because I got a call from the fracture liaison service to tell me to come in about a chronic fracture that I didn't know about. And because of your algorithm, I'm on medication. And now I'm have a good chance to have prevented my hip fracture. So there are more global evidence, but there's anecdotal evidence, and we're working on our financial ROI evidence to show benefit also for the medical risk holders. That requires more long-term outcomes data to be able to show that it's worth it for everyone. It's worth it for patients. It's worth it for physicians who are ultimately trying to do good for patients. It's worth it for medical healthcare systems so that we don't get to those chronic illnesses that are much more expensive. It's worth it for the medical risk holders. It doesn't really have a downside. So as long as people are in the know, at the forefront of where AI is taking us, at the forefront of value-based care and population health, then they should be very interested in what we have to offer.
Got it. I have seen, at least in academia, a lot more focus on population health AI, which I feel like is good momentum. And you and Zebra are doing a great job bringing awareness to this. But obviously, we're still early, right? Just like we're still early on the triage side of imaging AI. When you look into the next, 1, 3, 5 years, how do you see this evolving with Zebra and just overall?
Well, I see the medical risk holders starting to take notice. Ultimately, the person who holds the financial kind of strings often tend to dictate what happens in the healthcare system. And as soon as medical risk holders understand what we have to offer, they become our partners and try to direct their medical healthcare system to impose it. It's radiologists typically just find it as an additional thing they have to do, or kind of not in their typical workflow, or there's a resistance. And where many companies really targeted radiologists at first, that's fine, but it's a harder nut to crack. Radiologists are resistant to change in general. But the medical risk holders, they're not such a hard nut to crack. And if you show them that they're going to be saving money, then suddenly they're very interested in what you have to offer. And if the medical risk holders ultimately have the ability to impose solutions on the medical healthcare system that they service, then that's a direction that's very encouraging. And ultimately, we need to all work together, from patients to doctors to healthcare systems to medical risk holders. There's a whole chain of people that service the patients, and we need to work together to make that happen. So the radiology world, we've tried that and we have made headway, but it's a little more difficult. But so right now we're really focusing on the people that have much more ability to see the global picture. Radiologists really see the more narrow picture of the images as they go through case by case by case, as I still do in my teleradiology practice. So I really understand that world. If someone adds another secondary capture or another thing to do or another thing to look at, I'm skeptical and hesitant. So I get that point of view. But if someone who sees the bigger picture of population health, the bigger picture of how much hip fractures are costing them per year in their patient population as medical risk holders, suddenly they take notice and they say, listen, if you can prove that, then we're all in, and then we're going to make sure our providers use your product. So that's what we're working towards. And hopefully with additional information out there in the public, maybe we can get patients to request it as well. But as long as there's enough momentum from all the people who stand to benefit from it, then we hope to make large headwards into the system and really, really improve patient care.
This is fascinating. Is there anything that maybe I haven't asked, but I should have, or any additional messages you want to make sure you share about Zebra or about population health or our path towards adopting it?
That's a quite interesting question. I think that even within the AI world, there's a lot of room for collaboration. I think the platform companies, the AI orchestrator companies, patient information companies. I mean, there are companies that literally take information from the radiology report and route it correctly to the right physician. All those types of companies that really help us get from end to end are useful partners for us, and we're investigating many of them right now, because ultimately, as I said, AI is very nice. A lot of people can make AI, but ultimately getting the information to the hands of the right physician who will actually do something about the patient, that's actually been a more challenging portion of the end-to-end workflow that we're tackling right now, because American healthcare system is pretty disjointed. And because you came to the ER and got a CT scan, it's not so simple to figure out where to send that information so that you get the appropriate care that you need. So that's still been more challenging. And again, we're speaking to many companies who focus just on that. And we're happy to speak to anyone. I'm very available by email. And I'm happy to speak to any kind of IDNs, medical risk holders, even patients, or radiologists who are interested in learning more about population health and the use of AI, because we're really trying to educate the market, right? It's a new idea. And every time you come with a new idea, there's a lot of time and effort needs to be spent to really educate about that new idea. And we did that with teleradiology 20 years ago. And that was a new idea. We had to convince hospitals to try it with us for free for a while until they now, have been loyal customers for over 20 years. And similar things are happening in this new revolution of AI in radiology. And I'm looking forward to seeing it mature over time.
Me too. Thank you very much, Dr. Wimpfheimer. It's been a real pleasure, and it's been fascinating to learn about this. The folks who go out and try to create something brand new, whether it's global teleradiology or AI-based population health, are the folks that change the world. And I think that there's nothing cooler than that in business. So thanks for your time, and thanks for all that you're doing. And thank you, ImageWire show guests and audience. Thank you for joining us during these, I guess, like almost 40 minutes. So there's a lot of information here on population health AI. And I think that's it for the show. So everyone
Thank you very, very much for having me.
Oh, it's my pleasure. Have a wonderful day.
You can too.